Hello, everybody. Today we are going to discuss laparoscopic subtotal hysterectomy, which is one of the most important topics in gynecology. First of all, we should distinguish between the main types of hysterectomy. We have the total hysterectomy, where the entire uterus, including the cervix, is removed. Second, we have the subtotal or supracervical hysterectomy, which is done through a minimally invasive approach. Finally, we have the radical hysterectomy, where we remove the uterus, cervix, upper vagina, and parametrium, which is mainly an oncologic procedure. Laparoscopic subtotal hysterectomy is mainly indicated in patients who have symptomatic fibroids, abnormal uterine bleeding, or even if it is the patient desire. There is some contraindications for laparoscopic subtotal hysterectomy, like if there is any known or suspected malignancy in uterus, cervix, or ovary, if there is any cervical dysplasia, and if there is current pregnancy. There is preoperative evaluation checklist that we should fulfill, like some screening tools, pap smear, endometrial biopsy, and laboratory investigations like beta HCG to exclude pregnancy. The toolkit of the procedure should include four important items. First, the laparoscopic tower, energy device like bipolar, power morcellator, and the standard laparoscopic set from graspers and scissors. The patient is positioned in dorsal lithotomy position with a steep Trendelenburg tilt from 20 to 30 degrees. Monitors are placed in front of the surgeon, and carbon dioxide pneumoperitoneum is maintained at 12 to 15 millimeter mercury. We should remember that the uterine artery crosses over the ureter, and we could remember the mnemonic of water under the bridge. The water is the ureter and bridge is the uterine artery. Usually we use 3 to 4 ports. First, the umbilical port, which is the primary camera port, and the left lower quadrant port, suprapubic port, and right lower quadrant port. Let's go through the main steps for the laparoscopic subtotal hysterectomy procedure. We start by transecting the round ligaments, followed by transecting the utero-ovarian ligament and creating the bladder flap, sealing the uterine vessels, and finally we should amputate the corpus. We can manage the cervical stump by two techniques. First, the ablation to prevent the cyclic spotting. Second one is the closure to ensure hemostasis. Final check is mandatory, so we should decrease the pneumoperitoneum pressure to 8 millimeter mercury to reveal the venous bleeding, systemically inspect the sealed pedicles, and confirm no active bleeding from the cervical stump. There is common complications during the laparoscopic subtotal hysterectomy, like to injury the ureter during the artery ligation, and the bladder injury during the flap creation, and hemorrhage from any blood vessel. And we should know that we could do open laparotomy due to any of these complications. So we should know that convergent to open surgery is not a failure, it is just So convergent to open surgery isn't a failure, it is a judgment call for patient safety. Laparoscopic subtotal hysterectomy promotes a rapid recovery. Patients are often discharged on the same day, and it requires minimal analgesics and have a shorter restrictions, such as only 2 weeks of pelvic rest and avoiding intercourse. Main benefits from laparoscopic subtotal hysterectomy is the rapid recovery due to less tissue trauma, lower infection risk because the vagina isn't entered, and the potential for pelvic support by preserving the paracervical ring. Limitations include a 5 to 20% risk of cyclic bleeding from residual tissue and the ongoing screening requirements, as the patient must continue routine pap smear for life. In this case study, laparoscopic subtotal hysterectomy was chosen for a 45-year-old female with benign bulk symptoms who desired a rapid return to work. The surgery was successful and she was discharged to home in the same day. To summarize, the laparoscopic subtotal hysterectomy is a surgery that involves the minimally invasive removal of the main part of uterus while keeping the cervix. This procedure is best for a patient with non-cancerous issues and who wants a faster recovery. The most critical steps for safety are carefully locating the ureters and ensuring the uterine blood vessels are sealed correctly. The primary advantage of laparoscopic subtotal hysterectomy is faster recovery and avoiding complications associated with vaginal entry. Finally, these are the references, and thank you.